Good afternoon. I'd like to acknowledge the local custodians of the land in which we meet this afternoon and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome today and thank you for taking the time to be with us. Bit of housekeeping. We encourage you to place your questions in the questions box. We have Dr. Ellie Warren here today and she's going to be facilitating our questions box. So thank you for that, Ellie. And we would like it to be as engaging as possible. So this is your opportunity to ask those questions. If we can't answer them, we will get back to you with those as well. So pop those in and we'll get to those at the end of the session. Also, there will be a survey that will pop up at the end and I strongly encourage you to please complete that. That is how we get our data for future events and we track and report on every event that we do. So that is really important to us to have that feedback. And I thank you for those that are always consistently doing that for us because we do really appreciate it. The third item is that we are being recorded today and this will be available in our education library over the next 24 hours. So you're more than welcome to view it afterwards, which is a really handy option for all of us. I'd like to thank our three presenters that are here with us today. We have Dr. Kat Taylor, Director of Central Coast Public Health Unit. Welcome, Kat. Thank you for being here. Patrick Tashman, Immunisation Coordinator from Hunter New England Health. Thanks, Patrick. It's always good to see you. And Dr. Ellie Warren from Your Family Doctors and Yearn Aboriginal Health Service. Welcome, Ellie. We're going to commence now. I'm going to hand you over to Dr. Taylor.
Thanks, Melissa, and thanks everybody for your time. We thought that it would be timely to have a bit of a chat given everything that's been going on over the past couple of weeks. So let me just see if these slides are going to play nice with me. Can you guys see primary care COVID update?
Yes, looks great.
Okay, perfect. So yes, it's been 10 days since so-called Freedom Day, and you know, as you can see, we had a lot of lifting of restrictions back from Monday the 11th. So a lot of additional freedoms for vaccinated versus unvaccinated people, decreased restrictions on movement and gathering, and wild scenes at Kmart. So where are we now? Look, this is the New South Wales epidemic curve since the beginning of the Delta outbreak, which all started, you know, back in Bondi with that limo driver, a single case, and you can see there was quite a dramatic escalation, exponential growth really, peaking in sort of the second week of September, and steady downward trends seen since then, really through a combination of both public health social measures and also the increasing vaccination rates, which has been a fantastic collaborative effort across all sectors. But I just want to draw your attention to the far right hand side of this epidemic curve and note that, you know, although those in favour of opening up will crow that, you know, we've had less than 300 cases in New South Wales for the past 3 days. It's actually been plateauing for the past 3 days, and actually, unfortunately, we've now seen an uptick. I guess the experience today, for us at least, I'm not sure about our colleagues in Hunter, is that the numbers are substantially higher today. So I think it begins. Just to show, I guess, the distribution as well across the different local health districts. So what we did see was sort of a precipitous decline, particularly in the most affected LGAs that were more heavily restricted and where there were more intensive vaccination efforts. So we did see declines, you know, across the board in southwestern Sydney and western Sydney, which was predominantly driving that downward trend in cases. But unfortunately, the picture was not so rosy in regional centres. So, you know, in Hunter New England, we've seen a continued rise in cases, unfortunately, Illawarra Shoalhaven as well. And, you know, note this is kind of just looking at the past month. And then ourselves in Central Coast, we did see an increase, and at one point we were getting sort of 30, 40 cases a day for about a week there. And unfortunately, numbers starting to trend up again in, you know, Far West and Dubbo and things like that as well. In terms of what we're actually seeing, so this is the Central Coast epidemic curve presented by people's isolation status. And unfortunately, you know, all along we've seen kind of at least half of the cases be not in isolation, which I guess makes things difficult from an ongoing control perspective. And particularly in more recent days, we've seen an increasing proportion of cases be in the community for the entire or most of their infectious period. Our friends at Hunter New England, the lovely planning team, have also given us this epidemic curve of what's happening across the Hunter New England local health district. And as I mentioned, that sharp rise in cases, which has really been sustained, and concerningly, an increasing proportion of cases being unlinked, so unknown source. So unfortunately, the message out of this is that community transmission is here with us, and our days of COVID zero or suppression are behind us. Having said that, we are still really doing our best from a public health perspective to try and sustain some degree of public health control, in addition to the coverage the vaccination is giving us, which Patrick, we've got the privilege of hearing from him about. I'm just getting a notification that my network connection may be too slow. So if is anyone hearing issues with my sound, I can turn my video off.
You're sounding fine,
silence as continued. Okay.
Yeah, continue.
All right. So just diving a little bit further into the epidemiology, the other thing that we're seeing here is that increasingly transmission and cases are being driven in the younger age groups, which is essentially as predicted with the vaccination rollout that we've had, and unfortunately, not having vaccine available to the under 12 age group. So you can see here the black line reflects the expected population distribution, population pyramid by age group and gender. And then the bars reflect the proportion by actual case numbers. And so, sorry, my screen keeps playing up. And so you can see that there is, significant overrepresentation in that 20 to 29 year age group, but increasingly in sort of the 10 to 19 and 0 to 9 age groups. This graph is a little bit messier, but just to give you an idea, so the coral coloured bars represent the 0 to 11 age group, and the blue bars are the 16 to 29 year age group, and you can see proportionally the contribution has decreased in that age group, but the 0 to 11s remain high. So vaccination works, and it'll be great if and when we get the vaccine for younger age groups as well. But consequently, we are seeing a lot of exposures in, fortunately, quite well kids, but resulting in a number of childcare exposures, school exposures, etc. And that was what really drove transmission when the UK opened up. So we're watching this space with bated breath. Turning our attention now to vaccination and the good news story, this is just the Central Coast data, but as of the beginning of this week, we reached a target of more than 95% of people aged 15 over with at least one dose of vaccine on board, which is fabulous. And I think across the state now we're sort of more than 80% double vaccinated. So things are well on track there. And again, just wanted to acknowledge the huge collaboration. I saw a chart which was showing that the majority of those vaccines had been delivered in primary care settings, followed by local health district settings, and then pharmacy and other settings. So really great effort there to get our communities protected. And from a local health district perspective, there's a lot of work happening now focusing on, targeted approaches in particularly vulnerable communities. Sadly, something like 15 to 20% of our cases have identified as Aboriginal or Torres Strait Islander. And we are also seeing a real social gradient in terms of the cases that are being notified. So there is a real push now to try and close those gaps and address those inequalities and make sure that nobody's being left behind. So sorry, I'm going to try and fly through this because I'm really looking forward to Patrick's presentation, but just to give you, bring you up to speed on the latest public health advice. I know there's been lots of confusion and most of the stuff has come through by media as we are used to now, but just to give a summary of those changes. So in terms of the public restrictions, as I said, a lot more freedoms for fully vaccinated people. And for the purpose of these public restrictions, vaccination is considered, fully vaccinated is considered either has had 2 documented doses at any stage, or has a medical exemption or contraindication form, which is now kind of a standardised form that gets uploaded through the AIR. Now, masks, indoor areas, public transport still required, office spaces exempt. Visitors, 20 to your house, 50 for a picnic. Discretionary travel. So there's still travel limits in terms of between Greater Sydney and regional New South Wales. Essentially, if you live in Greater Sydney, you can travel anywhere in Greater Sydney if you're fully vaccinated. If you live outside Greater Sydney, and sorry, should I say that includes the Central Coast, the Illawarra, Shoalhaven, and the Nepean Blue Mountains areas in Greater Sydney. If you live outside those areas, you can travel anywhere regionally. Now, this is for things like outdoor recreation, holidays, etc. For any other form of travel that goes beyond these limits, there's still a reasonable excuse required. So, compassionate grounds, emergency, where working from home is not practicable, for example. In terms of work, travel for work is now unrestricted in New South Wales for fully vaccinated people, and there's no travel registrations required. And requirements for surveillance testing and things have all basically ceased. Although, different industries and employers are taking different approaches to their own programs for surveillance testing. And then I still haven't made it to the hairdressers, so hence the braids, but retail gyms and hairdressing and those sorts of higher risk kind of discretionary settings are now open to fully vaccinated people, contingent on those conditions. There's been big changes as well to the contact isolation advice. So your one-stop shop is probably the New South Wales Health website. So if you Google New South Wales COVID isolation fact sheet, it will bring you to the landing page of where all of these are stored. If you've been told you are a close contact of someone with COVID-19, there's now a difference between if you are fully vaccinated and if you're not fully vaccinated. So fully vaccinated people only need to self-isolate for 7 days, as long as they get another test on day 6. And if they remain well and that test is negative, they can, as I said, finish the isolation. But then for the remaining 7 days of the 14-day period, work from home where practicable and not go into any hospitality settings or high-risk settings, even if it is a place of work. And also the requirement for the day 12 test is still in there. Those that are unvaccinated, the previous close contact advice remains. So getting tested immediately, self-isolating, 14 days, and then on day 12, getting another test. Now, oh yes, if you live with the COVID-19 positive person, so a household contact of a case, the period of isolation starts from the day that the case received their positive test result. Hopefully that makes sense. Now, casual contacts, that advice has changed slightly as well. So the advice is to get tested immediately and self-isolate until you get a negative result. And if that test was less than 4 days since the exposure, then they need to receive another test on day 6 or later after the last contact with the COVID-19 person. But assuming they remain well, there's no need to self-isolate whilst waiting for that second test result. So self-isolate for the first test, and if that one was too soon after the exposure, there needs to be another one, but there's no self-isolation needed for that one. Another one which comes up quite a bit is secondary close contacts, and largely this has sort of dropped out of being actively managed. There is some wording within the close contact fact sheet which says if you live with someone who works in healthcare, aged care, disability or correctional facilities, it's important that they speak to their employer about returning to work. So there may be provisions in place that different workplaces have for people who are living with close contacts, not cases. The other key one is, unfortunately, with the growing number of, childcare settings, for example, often little kids can't isolate on their own and they require a carer to co-isolate with them. Now, the advice for people in this situation, the secondary close contacts, is that they need to self-isolate with that person for their full isolation period. Now, unfortunately, because a lot of children are not vaccinated, the kid is in it for 14 days, and so the person that's caring for them and co-isolating with them is also in it for 14 days. That's irrespective of that person's own vaccination status. Now, I know logically it seems like a bit of a disconnect, but essentially it relates to thinking that the person who's the close contact could turn into a case at any point during that 14-day period, which then would sort of create a risk period for the person co-isolating with them, you know, potentially beyond the 7 days, and it's based on the person who's the close contact themselves and their risk of turning into a case. So hopefully that makes sense. Now, another big one which we get a lot of questions about is what is the advice for recovered cases? And this has been sort of in play for a little while now as well. The first one is once someone's been medically cleared, they're considered to be no longer infectious, and there are, you know, some quite well-established clinical protocols around that. So, you know, if someone has their clearance certificate from New South Wales Health, which is typically issued by SMS, but will kind of open up to a formal letter, then there's sort of no need to call public health and check, are we sure that they're not infectious anymore? It's a medical clearance process. Previously, there were also exemptions under the self-isolation orders for people who had had COVID to be exempted from testing, vaccination and self-isolation if they became a close contact for 6 months following recovery. Now, yesterday, the self-isolation orders were updated and all of those exemptions have been removed. So there's no longer a need to delay vaccination. There's no contraindication to receiving vaccination if you've recovered from COVID pretty much as soon as you've recovered. So the exemption for vaccination has been reduced to 6 weeks following recovery. So a person is expected to get vaccinated within 6 weeks of their recovery. And then similarly, they are no longer exempted from testing, although there is recommendation that they shouldn't be ongoingly tested if they're asymptomatic. And there's also no longer an exemption from them having to self-isolate if they become a close contact, just to align with the other advice for vaccinated people. So routine surveillance testing not recommended. Yep, I said that. And now I guess the other question is, well, what if they develop respiratory symptoms during that 6 months period of having recovered from COVID? Look, I mean, generally, we're still learning a lot in terms of reinfection and periods and immunity, but generally we wouldn't suggest to be retesting people who are symptomatic and have recovered from COVID for COVID if it's been less than 3 months since they recovered. But I guess that's a clinical decision. And if you do test them and they test positive, then we'll certainly need to kind of work through interpretation of that test result and whether it actually does reflect reinfection. I won't go into this in detail, but just to flag that in accordance with and in preparation for the surge in cases, there has been a revised approach to public health follow-up, and also, you know, considering that we're moving into this living with phase of the pandemic rather than, you know, an aggressive elimination or suppression strategy. So in line with that, there's now an increased automation for different contact tracing and case alert processes. So, you know, for example, rather than people getting contacted by New South Wales Health if they've been somewhere where there's been a case, they'll now get sort of push notifications through their Service New South Wales app. And so, you know, people continuing to QR check into places still remains quite critical because that's the way that people are going to be notified that there's been a case there. Contact tracing as well, that's being scaled back to sort of an initial contact that's made with contacts to inform them of their contact status. This is for close contacts and their isolation requirements. But then following that initial contact, it's essentially a self-monitoring and release process that happens for the contacts. There are additional requirements under the self-isolation orders for cases and workplaces to notify. So cases, for example, are now obliged to notify their employer and anyone that they've been in contact with and their household. And if they attend an educational institution, whoever is the relevant COVID contact person for that institution. So they're now required to do that. So it's pushing a lot of that back onto cases themselves. And workplaces as well, where a case has occurred in an employee, are required to notify Safe Work that there's been a case there. And they're also required to notify if 3 or more cases are reported in employees over a 7-day period. I mentioned the self-release from isolation for contacts, noting that cases, so confirmed COVID-19 cases, are still released as part of a clinical process by the clinical team. There's a decreased focus on public exposure venues. And so, as I mentioned, most of that notification will happen through the Service New South Wales app. But I think the key message to really try and convey to community is, look, COVID is here, COVID is everywhere. And any time you go out of your house or have people over, you could be being exposed. So really just a reminder for people to, stay alert for and maintain some sort of COVID safety practices, and really for businesses to really prepare their COVID safety plans as well. So I suppose that brings me to another question which comes through quite frequently, and unfortunately we are seeing this increasingly. So, what if someone comes to my practice who's a COVID-19 case? And the typical sequence of events is, somebody will test positive for COVID, they'll go and phone the GP that they saw a few days before and tell them before public health has even gotten the notification that they're a case and had a chance to interview them. So there is a bit of a circular process happening at the moment, but just to flag that most of you are probably familiar with the healthcare worker risk assessment framework that was developed for New South Wales health settings. And, we've been working with many practices that have had exposures in our area about, risk assessing their staff according to that matrix. There is actually a community settings risk assessment matrix which is being developed for healthcare services. And this is really for, general practices, allied health, dentists, that sort of thing, to assist with assessment of contacts that are both staff and patients. I don't believe this has been finalised yet, so unfortunately I can't present the detail of it here, but just to let you know, it is in development and consultation. So this is small, I appreciate, but it's really just to kind of show that there's a differentiation for staff assessments between whether someone's vaccinated or unvaccinated, and really just to draw your attention to, I guess, the number of kind of red and yellow boxes, so the red being close contact and the yellow being casual. So obviously in unvaccinated people, there's a lot more kind of red and yellow boxes under the same sort of conditions. And for unvaccinated people, there's more of a reliance on risk mitigation through PPE, for example, and physical protections. So being vaccinated does make a big difference to the contact assessments, and then the according number of staff that would need to be furloughed potentially. So I just thought I'd run quickly through a little scenario just to kind of work you through the types of things that are considered and the types of strategies that you could consider putting into place to minimise, as I said, the number of staff that need to be furloughed, or the chances of needing to shut down your practice, for example. So this is Mrs. Jones. She's come in for an appointment on Friday, the 15th of October, and then on Monday she phones the practice and tells you she's tested positive for COVID. What next? So what would be required next is basically reviewing that patient's exposure. So looking at Mrs. Jones's movements, where did she come through, which spaces was she in, how long did she spend in the different areas of the practice, what was the nature or duration of her visit, was it a procedure, was it a counselling appointment, was she distressed, were there any aerosol generating procedures, or was she coughing, that sort of thing, was she wearing appropriate PPE, and were there any direct interactions between her and any of the other staff or patients? So sort of having a think about that exposure. Then the next step would be to basically compile a list of anybody present in the same space or spaces as the case, so patients, visitors and staff. Then I guess reviewing on the other side the mitigation strategies that you have in place at your practice. So what's the vaccination status of all of those people that have been exposed? What degree of PPE was worn by those people? And also considerations relating to the size of the space that she was in, depending on sort of actually the square metre, floor area of your waiting room, your consult space, your treatment room, for example, and what kind of distancing was utilised within those spaces. And all of that information then gets fed into interpreting the risk assessment matrix, and there are actually two different matrices. So, well, there's actually more than that. There's a staff matrix, which takes into account vaccination versus unvaccination. And then there's a patient matrix, which is similar to another matrix which has been developed looking at community and workplace exposures. And so again, that does look at the difference between vaccinated and unvaccinated, and it also takes into account whether there was contact within 1.5 metres, or whether it was just being sort of in the general same airspace, which will then depend on the kind of physical area of the room and the duration of the contact. So once these assessments have been done, patients and staff would be notified, and ideally, I guess that would be done by the practice. In terms of the public health unit, as always, we are here to support you. I suppose just mentioning, as things pick up and this becomes more commonplace, I suppose it's hoped that practices will feel more confident to kind of take on these contact tracing and risk assessments themselves, and to be able to manage in-house. But we're certainly always here if you want to pick up the phone or shoot us an email to help work through some of those risk assessments. So give us a call if you need. Okay, so in terms of further detail, so let's say she's sat in the waiting room for 20 minutes, and the waiting room is a less than 100 metres squared, so less than 10 by 10 space. There were 5 other patients who were wearing masks and 2 reception staff who were wearing masks and eye protection who were present in that waiting room area. She was then taken into the consult room for a 12-minute consult. She wore a surgical mask for the duration of that visit, and the healthcare worker that saw her was wearing a surgical mask and eye protection. There were no concerns or breaches to PPE, and all staff in the practice are fully vaccinated. Noting that full vaccination for the purpose of risk assessment, as opposed to for the purpose of getting into your hairdresser, is defined as having had 2 doses and being more than 14 days past your 2nd dose. So in terms of what this washes out as, referring to the matrix, the reception staff would be considered to be monitored for symptoms only, so they wouldn't actually need to test and isolate as casual contacts. The treating doctor would be considered monitored for symptoms as well, because the consult was less than 15 minutes, which is one of the cut points there. And the patients would be considered casual or close contacts depending on their vaccination status. So if they were unvaccinated, they would fall into the close contact because she has sat there for 20 minutes. But if they were fully vaccinated, then they would be considered casual contacts. So I guess the key things, like just to work you through thinking through this example, is the duration of the consult. So 15 minutes is kind of a threshold there. Use of eye protection is still relevant, particularly if there's partial or unvaccinated people in the equation. Yes, and then vaccination status is really the key thing that will make all the difference. So maybe in terms of thinking about how to mitigate this scenario further, whether or not the waiting room could be rethought in terms of not having a lot of people sitting around in there for 20 minutes. So I know a lot of you have already made changes to your waiting room processes and practices with respect to having people wait outside or in or whatever until they're actually ready for their appointment. So a few things for consideration there, but that matrix should be finalised soon, and will help greatly, I think, in people being able to self-assess their own practice exposures. Oh, sorry, that was just an extra slide. So that's all that I had. Bit of a whirlwind tour. There's been lots of changes over the last 2 weeks, and appreciate everyone's grappling with the changes and the speed of change. But yes, we are certainly moving into a new phase of managing this virus now. Thanks.
Thanks, Kat. I might jump in with a few questions from the GPs on the call. That was fantastic. Thank you for so much detail. It's so wonderful, especially to hear you talk about the risk matrix. One of the questions relates to what we would do in the situation where we have an unvaccinated staff member. So I gather that you would use the unvaccinated healthcare worker risk assessment matrix. Could you just talk us through that a little bit?
Yeah, so it's quite similar to the previous version of the healthcare worker risk assessment matrix, which didn't factor into account vaccination status. However, if that healthcare worker is wearing complete PPE and there are no breaches, so by which I mean, you know, an N95 mask, eye protection, etc., then they are still, you know, considered low risk essentially. So PPE is thought to effectively mitigate that risk. But if there's, you know, if they're in a surgical mask only, or if there's been any breaches, or if there's, you know, aerosol generating behaviours or procedures, then it wouldn't take much to kind of flick over into close. In terms of the isolation requirements as well, so I guess people would still be furloughed for 14 days. And if they were unvaccinated, then they would need to isolate for the full 14 days as well. Whereas people who are fully vaccinated are furloughed still, unfortunately, for 14 days, as in can't come into work or high-risk settings, but they can de-isolate and, you know, go to the shops or whatever they need to do after the 7 days if they're fully vaccinated and test negative at day 6.
Right, thank you for that. And what about the role of P2s and N95 masks in fully vaccinated staff? Is there a need for that now? I guess if we're talking about unvaccinated patients possibly, but comment on that if you could.
It's a good question. So just from memory, sorry, I'll just flip back to that slide. So yeah, I mean, essentially it can make a bit of a difference in the sort of highest risk scenario between kind of casual and close contact. But it's kind of it's sort of a risk assessment, like a bit of a judgment call in terms of, you know, surgical versus N95. But N95 basically removes the question of whether it is considered casual or close, and actually reduces it just to monitor for symptoms.
Yeah, and are you routinely checking that those N95s are fit tested? Because not many of us in GP land have had proper fit testing. Does that still qualify?
Yeah, so I can only speak from experience of what we're doing in our healthcare settings, and we do take that into account. So I guess if a mask is, you know, ill-fitting or, you know, not tested or that sort of thing, it's considered, you know, not to be sufficiently protective when we're doing our own healthcare worker risk assessments.
And how important is eye protection in a routine GP consultation? So we're all wearing surgical masks, but possibly not all of us are wearing eye protection for all face-to-face contact?
So I mean, for transient contacts, it doesn't really make a difference. So it's still monitored for symptoms if you're fully vaccinated, if you're wearing just a surgical mask, versus if you're wearing surgical mask and eye protection. It's more in the medium risk scenario. So that's face-to-face contact within 1.5 metres, which would be a consult room really, less than 15 minutes, or, you know, greater than 30 minutes in a closed space. So it does make the difference there between being a casual contact and being just monitored for symptoms.
Thank you. Is there any point to temperature checking? Some GPs are still doing this and some aren't.
It is a vexed question, and New South Wales Health stopped doing it. I think it was about 2 months ago, and part of that was related to the potential risk of, you know, needing to get within close proximity of somebody to take their temperature. So it's now, you know, I guess discouraged, other than if there's some kind of automated heat scanner or something that, you know, doesn't require someone to get within proximity of the person. I guess just because of the pretty low sensitivity and specificity of temperature checking. So it's probably not adding a lot. And unfortunately now the epidemiology screening is not really adding a lot either, given that, you know, we're coming into community transmission. So, you know, previously asking about, symptomatology is still important. So definitely keep screening on symptoms. But, you know, asking where someone's been and seeing if they have a temperature is probably not going to help a lot.
Yeah, thank you. And just 2 more questions and then we'll fire off to you, Patrick. Do you agree with visitors having to have COVID tests before they go to residential aged care facilities? And should we be asking our GP patients to do the same before they come and see us?
Yeah, it's a really good question, and certainly we're in an era of transitioning in terms of testing methodologies as well. So obviously the role of rapid antigen tests is taking off, and a lot of people are procuring these privately, and there's a lot of aged care facilities that are implementing them as well. So I mean, they do have some utility. It's particularly useful in workplace settings where people are turning up every day, and you can kind of really quickly pick up any new infections. In terms of visitor screening, I'm not sure that they'd necessarily have the sensitivity for someone that was pre-symptomatically infectious, for example. So yeah, there's no clear policy on it, but it is certainly a topic of kind of active review.
Thanks, Kat. And just one last question. I guess this is a bit more specific, but it might be relevant to some practices where there is an unvaccinated receptionist or other staff member who does never plan to get vaccinated. How do we approach this?
It's really challenging, and I suppose there's all sorts of different, levers which are being pulled around the place to encourage people towards vaccination. I suppose, at the end of the day, it's kind of an informed consent type thing, and noting that person would be in the event that a positive case came through, there'd be circumstances under which they could be considered close contacts and have to isolate for 14 days, and maybe after having to do that for a few times they might get sick of it and get vaccinated. But noting that there's certainly a lot of reasons and strongly held beliefs around this, so I'm not sure that there's an easy answer to it. But I think just trying to in terms of, you all know this from counselling patients yourselves, trying to maintain an open conversation and, stay non-judgmental and remain approachable to having conversations rather than just kind of shutting people down as anti-vaxxers is helpful.
Yeah, definitely. Yeah. Thanks so much. Patrick, we'll go to your talk now. We're really excited to hear from you. Thank you.
Oh, let's start at the beginning. Can you see that, Ellie?
Yep, looks good.
Great, thank you. Hello, everyone. Thanks, Kat. That was a tour de force of all the current changes, and I appreciate everyone's tuned in to get on top of all those current changes with things opening up, and we just thought we'd throw in a bit of vaccine information. So I appreciate that. So I'm Paddy Cashman, the Immunisation Coordinator in Hunter, New England. And just a reminder, we're meeting on Aboriginal country and encourage people to have a look at the Uluru Statement. It's only one A4 page. It's just a beautifully written document. This is the flash one, but just read that one-page statement. It's really lovely. And just a reminder that the immunisation rate for Aboriginal people is about 20–25% behind the rest of the community. Today I'm in Tamworth. We're working with the RFDS. I'm at a youth club here in Western Tamworth, and really important that we get the Aboriginal immunisation rate up in our areas. So this is some stuff that the epidemiologists in Hunter, New England put together looking at COVID cases in August and September and the first week of October. And as you'd expect, the older people have all been vaccinated. That was the phase 1. Younger people less so, and unsurprisingly, the cases we're seeing are in young adults, and young adults are moving the virus around the community. Now, the older people are very good at coming to the practice all the time for influenza vaccines. Young people are less frequent visitors to general practice, so they're much harder to locate and find, but they're really the target. So in your anything you can do to encourage young people to come into the practice and have that COVID vaccine is just really important. So that's the real big target at the moment. So if you can see the age profile, this is for all of New South Wales, and you can see again the less younger people vaccinated. So if you actually look at the rates on the right-hand side there, you can see that they're up into the high 80s and 90s for most age groups, and then they fall away at less than 35 into the 70s and down below 70% for older teenagers. So it really is those young people who are able to be vaccinated at the moment that we really need to be offering the vaccine to. And we want to give everyone the opportunity to be able to have this vaccine, and the more people vaccinated, the better. A lot of countries have opened up ahead of us, and the experience is, if we compare to European countries, France and the UK, in France they're still doing a lot of the mask wearing and social distancing. In the UK less so, and we're seeing the rates of hospitalisation rise in the UK more than France. So although the vaccine is incredibly good, and 12 months ago we would just love to have had such a good vaccine, so this is terrific, but it still needs a hand in these early days with social distancing and mask wearing, you know. And if you could save someone's life just by putting a little bit of paper over your mouth, then why not? It seemed like an imposition when we started, but I think we've got used to it. So although we're going to open up, I think mask wearing, the UK experience teaches us that mask wearing is still very, very useful. So the rates in the Central Coast for the first dose is over 91%. This is up to the 17th of October, 4 days ago. And second dose, 78%. So hopefully most of those second dose people will get their first dose people will get their second dose, and we'll be looking at sort of 90%. And similar in Hunter, New England, just but a bit further behind with that second dose. So they're really good high numbers, but we're going to need those high numbers. They're not, we're going to need every one of those people. It's really important. In terms of the actual numbers of vaccines themselves, it doesn't teach us much except to say that general practice is doing the heavy lifting like they do with childhood vaccines and have done for decades. Vaccines is really the domain of general practice, and general practice, unsurprisingly, are doing really well. So you may be able to see the vaccines that you've given in these numbers here. So just a reminder, we're becoming very familiar now with using the Pfizer vaccine in general practice. It is very delicate. It's a little string of mRNA. It's got the 4 lipids around it, so it is very delicate. So we do have to treat it very carefully. So we know we have to just rotate it gently when we're preparing it. So no shaking, no hitting the syringe with the bubbles. Just because we're familiar with it now doesn't mean that we're blasé, and really important that people get that vaccine in good condition, because they're coming to you as a professional place. And also just a reminder about injection sites. I mean, really, really important. We're not too high, not too low. We're coming into a warmer time of year, so people come in with clothing. You can generally expose the deltoid really well. And of course, there's that condition server, shoulder injury following vaccine administration. There's some great fact sheets on that. So really important that you expose the deltoid properly and give it properly into the deltoid. You don't want to be giving it too high and injecting vaccine around the bursa and giving someone a server reaction. So really good technique. So good with the vaccine, good technique. Just because we've done a lot of them doesn't mean we get blasé with them. But sometimes people can have a reaction, and thankfully the blood clotting TTS problem, we're not using AstraZeneca so much anymore. It's very rare, but we did have it's about 7 or 8 deaths in Australia from that. Up on the TGA website. And one of the important things with the adverse events is that we keep reporting them because it's really transparent. So this is up on the TGA website in their weekly data. This is from the 10th of October. You can see here over 30 million doses given. The TGA have had 69,000 adverse event reports. So really important if someone's had an adverse event, not a trivial adverse event, but an adverse event. So on the 10th of October, the TGA had received 269 reports of myocarditis and 725 reports of pericarditis alone. And the numbers down the bottom are from the UK. So you can see there, Pfizer for myocarditis, about 7.4 per million and 5.6 per million for pericarditis. Moderna, a little bit higher. So the Moderna is mainly used in the pharmacies at the moment, 28 per million doses, myocarditis and pericarditis 17. So this is very, very rare. It would be unusual to see your patient develop myocarditis or pericarditis, but we should tell them about it anyway. So this is some information just from a Targis fact sheet on myocarditis and pericarditis. So this is developing chest pain, usually about 2 days or so after the vaccine. So you do have to advise someone that develops chest pain to get investigated. Now the problem is there's a lot of chest painish type of presentations after the vaccine. So we've got about 20 odd in Hunter, New England that we've investigated. They're not pericarditis or myocarditis, but they're young people with a chest pain type of presentation. So whether it's anxiety or what, it's difficult to know. We're still investigating them. We need to learn more about this sort of cohort of patients. So we've got this tension at the moment with not wanting to send too many people to A&E because A&E are going to be smashed with COVID cases when we open up. And obviously there'll be a concentration of COVID cases in the hospital. So you don't want to be sending people that don't have COVID to the hospital, especially if they've only just had a vaccine, they wouldn't have built up full immunity, and not wanting to miss cases, and obviously don't want to advise people having chest pain not to get it seen to. So this is a real tension at the moment. And my understanding is in general practice, there's some new rules about reimbursement for doing ECGs in the practice that make it less attractive to do it. But the investigations, 12-lead ECG, obviously troponin, chest X-ray, don't have to jump into echoes straight away. So an elevated troponin and ECG changes, you would be referring those people in. Now, happily, unlike the VIPIT or the TTS, this is not a fatal condition. People do need to go to hospital, do need anti-inflammatories, they do need treatment, but they sit there for a few days and then they're discharged and it's not potentially fatal. So this is a much better adverse event to be dealing with. But it's incredibly rare, but the differential diagnosis for you in general practice is quite difficult, especially with the resourcing and not wanting to send patients into A&E as maybe you frequently did. So that's, I don't have a solution. I'm just acknowledging that it's a difficult space at the moment. In AusVac Safety, something we set up, helped to set up, it's looking at contacting people after they've had vaccines. We were doing it with children, obviously in COVID time, we're now doing it with adults, and we've had 4 million surveys back through AusVac Safety, 55,000 from Aboriginal people. So this is giving us really good data. So this is early signal detection. We've got some very good statisticians working in the team who look at this data each, it was each week, now it's each month, looking for safety signals, and now of course concentrating on Moderna now that that's new, and as new vaccines or new age groups open up, we'll be keeping a close eye on that. So this is the sort of data it presents, and this is all up on the AusVac Safety website. It's public data. So if you've got people who are nervous about having the vaccines, you can direct them here. So that's 1,800,000 survey responses for the first dose of Pfizer, and 1,374,000 for the second dose. You can see on the graph here the immediate adverse events. So these surveys are answered on day 3 and day 8. The immediate adverse events of local reaction, fatigue, headache, more for the mRNA vaccines on dose 2, and as you'll remember, it was the reverse for the AstraZeneca vaccine. But what we find, we send surveys on day 3 and day 8, and most people that have had symptoms on day 3 have bounced back by day 8. So up here on the top left, in blue, less than 1 in 100 people seeking medical attention after the dose of first dose of Pfizer, and just over 1 seeking medical attention. So these are incredibly safe vaccines. Good to tell people they need to have some Panadol or similar in the house so that they can manage these sort of symptoms themselves and give them good information, especially now we're going to vaccinate young people. Young people aren't used to feeling crook, and they don't know, if they're about to die or whether they just need to take a Panadol. So good information when you're vaccinating people is really important. And about 20% find that they are missing work or routine duties study the day following the second dose of Pfizer. So they do get knocked around a bit, but it's better than getting the disease. Unsurprisingly, women are better at responding to the survey, and we do have a lot of Aboriginal data, and we have separate data sets for Aboriginal people. So if you're working with Aboriginal people, we've got those separate data sets showing the rates for Aboriginal people. Aboriginal people ask me, well, these trials were done overseas, how's it going to work with Aboriginal people? Now we've got these data sets in AusVac Safety. Now, the big thing that everyone's thinking about now is third doses. And as you know, 2 weeks ago, ATAGI gave advice to give a third dose. So this is, as we know, thought of as a third primary dose. So obviously when the COVID vaccines first came out of the lab, they didn't come with a schedule on how to give them. That has to be found out. Now, we started with 2 primary doses, 3 to 4 weeks apart. It's looking like for some people it will be a primary course of 3 doses. So, you know, with hepatitis B vaccine, we give one now, one in a month, and then the third one 6 months down the track. We may see something like that in the future with the COVID vaccines, with the mRNA vaccines. But at the moment, ATAGI is recommending a third primary dose between 2 and 6 months after the second dose for people with severe immunocompromise. So this is just not anyone who has a chronic illness. This is people who are severely immunocompromised. So they're the good people to recall and give another dose to before they bump into the virus. But I'm sure it's a very useful audience out there. Oh, no, the healthcare workers, not so young. But anyway, as you get older, you might not know this. I certainly do. As you get older, your body doesn't function quite as well, and your immune system, unsurprisingly, is no different. So this is this idea of immunosenescence. It's something you would have bumped into in like cancer medicine. As you get older, your immune system's less able to clean up those aberrant cells. But in vaccination, an older person giving a vaccine is obviously not going to respond as well as a younger person. Still build up antibodies, but you remember thymus, you've got as a young person, it's maturing white blood cells and T cells. So you give a young person a vaccine, really good, that decreases about 3% a year. And by the time you're in your 50s or 60s, you've got nothing left. So you're obviously not going to respond to the vaccine. Obviously, we're used to this with this terrible disease because it's much, much worse with older people than it is with younger people. And there's not many blessings with COVID. The fact it's sparing of children, I think, is just fantastic. It would be an awful thing if this disease was terrible for children. So that's a good thing with COVID. But with immunosenescence, the vaccine's not going to work as well with older people. So in Israel, the United States, they're starting to introduce third doses for people over 50 or 60. We may see that down the track here. Pfizer has put in an application to the TGA in Australia for consideration of third doses for I don't know what the application says, but I think it will be probably something of giving third doses to people over 50 or 60 or so. Younger people have a better response to the 2 doses. There may be need for booster doses for younger people down the track, but not yet. But today, the advice is severely immunocompromised patients, give a third dose. Everyone else, there's no advice in Australia to be giving booster doses at the moment. We'll have to wait for that advice. It looks likely. We just don't know. In the future, we don't know what it would look like. From first principles, you think of a disease like chickenpox, you vaccinate or you get the disease as a child, then you bump into the virus as you go about your life, down the supermarket, when you go to work, and that bumps up your immunity and you stay topped up most of your life because that virus is circulating in the community. There's no evidence that that is happening with COVID at the moment. Whether it starts to behave that way, we just don't know. Or whether like you get other coronavirus, common cold type minor infections every year, and that immunity doesn't seem to last, and then in the next winter you also get common cold type episodes, but that immunity doesn't seem to last. And exactly what will happen with our exposure and our immunity, we just don't know. So at the moment, third doses for immunocompromised, likely third doses for people over 50 or 60, I think. I have no inside information on that. And younger people, we just don't know. And what will happen with the natural history of the circulating virus and our immunity, we just don't know. So from first principles, we'd expect the booster doses to be given with the messenger RNA vaccines. Just a reminder, the AstraZeneca is a vector, so it's put inside the chimpanzee adenovirus. Now it's used a chimpanzee because obviously our immune system will recognize a human adenovirus and chomp it up. So it's put inside a novel adenovirus, a chimpanzee. So if we keep giving AstraZeneca, that chimpanzee adenovirus vector won't be novel anymore, and the vaccine won't work. So from first principles, we'll be expecting boosters to be given with mRNA vaccines rather than AstraZeneca. And it looks like a mixed schedule. So 2 AstraZeneca followed by mRNA gives you really good immunity. So that's probably the way ahead. Now in the UK, in the first 6 months of this year, they had 51,000 COVID deaths, but only 256 of those occurred after 2 doses. When you take out the severely immunocompromised people, but even a lot of those were very elderly. So it gives you incredible protection. Now they are seeing in Israel, the United States, even after 2 doses, even at that severe end, that protection's not quite as good after 6 months. So we'll probably see that 3rd dose come in for some people, possibly healthcare workers and older people. But the first 6 months, really good protection. And it's really a disease now in America. You would have heard the term, it's a pandemic of the unvaccinated. And that's really the case. So everyone, you can get vaccinated. So both people who, the first thing is to make sure everyone's offered a vaccine. And then as the percentages go up, we're going to be bumping into more and more people who are reluctant to have the vaccine and having those conversations. And of course, long COVID, we haven't got a big experience of that in Australia, but we soon will, I suspect. So that's something else to prevent. So not just keeping people out of ICU and fatalities, but also preventing longer term. So long COVID is up to 12 weeks, and post-COVID syndrome are things that continue for over 12 weeks. But
Patrick, I might just jump in there. Sorry, Patrick, It's Ellie here. So we've got lots of questions coming in and only a couple of minutes left. So if you're happy to do a couple of questions, or just let us know the most important points before we ask just a couple of questions. Thanks.
Yeah, sure. All right, I'll just quickly run through this and then we'll do questions. Thanks, Ellie. Apologies. So how do people know what they know? So this is what we call heuristics. So it's a mental shortcut to make a rapid judgment when you've got a huge amount of information, and it helps people balance up the risk and benefits of a decision. Now, I won't go through this because of time, but you think about voting, you know, people make really important decisions like who's going to run the country just on sort of, you know, the coloured shirt a politician wears on a grab or something. So people are sometimes making very important decisions on vaccination just on weighing up different bits of information they're presented with. So as Kat said, if we're talking to people who are worried about having the vaccine, we treat them with respect. They might not have it today, but maybe they'll come back next time. But just understand that there's lots of different ways people make decisions. So we put this, a group called COSI, Collaboration on Social Science of Immunisation, and this is a paper we put in the MJA earlier this year. And in America, there's lots of people who are unvaccinated who have died. This is just a story about 5 radio announcers who are anti-vaccination, used to spruik anti-vaccination messages. All of them chose not to be vaccinated. All of them got COVID, and all of them died. Thanks, Ellie.
Thanks so much, Patrick. We have a few questions coming in. That was fantastic. I wish you could talk for longer. There are a lot of questions here just about using our Pfizer vaccinations that are going out of date to give boosters for our health workers. What do you say about that?
There's just no recommendation to do that. So no, it's terrible. I mean, 2 months ago, every dose was so precious, you know, we just didn't have enough vaccine for the people lined up outside the practice. Now, because they're very short dated, especially once they're thawed, no, we shouldn't just be giving them randomly to extra people just because they're in our fridge and we've got this aversion to throwing them out and not being used. We have to follow the recommendations at the moment, I think. But that's a great question. And if you are over tempted, well, I don't know.
We know the official line now.
Yeah.
Now, what about if someone has myocarditis or pericarditis as a reaction to the first dose of mRNA vaccine? What is their preferred vaccine for the second dose?
Yeah, that's a really good question. So we do look at all these in quite a lot of detail, these case reports of adverse events. Dr. Kate Jardine, a pediatric cardiologist in John Hunter, we go through these in quite detail, and some of them are looked at the state level. We don't just give the second one straight away. We would wait until they're better, and there's no really good advice whether you go back to a non-mRNA vaccine like AstraZeneca or wait till they're completely better and then give the mRNA. Both I've seen both of those courses followed, and I haven't seen a strict guideline. I should say with the myocarditis and pericarditis, the pathways for general practice is absolutely fantastic. It's really well thought through, and that will really guide you through the steps. So if you are seeing any chest pains after the vaccines, please use that pathways. It's got the investigations and things to do. It's excellent.
Oh, thanks, Patrick. That's fantastic advice. Yeah, and there's just a comment from Erica Drew here as well about promoting vaccine Pfizer availability to pregnant women, which is really important because they're in the younger age group that have a less percentage vaccinated, haven't they? We'd better close up there, I think, Patrick. I think Mel just wanted to mention health pathways very briefly. Thanks, Mel. Thanks so much, Patrick.
Thanks so much, Ellie. Thank you, and thank you, Patrick. Yeah, we are running out of time, but I'd like to highlight the changes to the CC-ITC. A copy I have actually put into the handout section on your little dial, which is underneath the questions box. So if you're on top of that, you'll be able to see it. And also there'll be a copy of that in the education library, along with a copy of today's recording. The PHM will keep you updated on the new developments as they arise in that area, and any questions, could you please contact the Health Pathways team. I'd like to thank all the presenters that were here today. We really appreciate your time, and the content was just amazing. As I mentioned, there will be a survey at the end, and we do strongly encourage you to complete that as well. So thank you, everybody, for taking time out of your day, and I wish you to have a beautiful afternoon. Thanks, everyone.